Thank you, Momita. Thanks a lot, dear. Good evening, everybody. Good evening, dear faculty, and the other and the delegates who have joined. It's a great pleasure to be having Dr. Maitree and Dr. Nidhi with us today. Thanks a lot for being there. Just before we start the case discussion, I would like to tell everyone about our college, the Indian College of Anesthesiologists. I take great pride in informing everybody that we have been running these webinars for the last more than 4 years. And today we will be hosting the 217th webinar. Consecutively, every Wednesday we do it, and it has been appreciated by our faculty members and by our students who actually view it later on. If they can't be attending the same day, they view it later on the YouTube. And it's a very, very popular. These classes are very popular. That's because we have such esteemed faculty like we have today. Just to let you know that from tomorrow, we are starting our annual conference. This is in Lucknow, the 5th International and the 15th National Conference of the Indian College of Anesthesiologists. This is being organized by the Department of Anesthesia, King's George's Medical College. The organizing chairperson is Dr. Monica Kohli, and this is Dr. Tanmay Tiwari. He is the organizing secretary. You can, of course, do the last minute spot registrations and join us because 13th, 14th, 15th, 13th is the workshop, 14th and 15th is the main conference, and you are really going to enjoy it because if you can see on this, on the computer, how on my presentation, what important topics there are for the workshop tomorrow. And later on, we have important lectures and panel discussions by very esteemed faculty from India and abroad. We have, of course, association with ASA and SAMBA, and their leaderships will also be participating in this conference. We have a very interesting PG mentoring session, which was really praised last year in Bangalore. That was the first time we have had it. And it has been so popular that all the students would like to have this continued. So we shall be having this on Friday evening. So after telling you about this part of the college, you should also know that we are publishing the yearbook of anesthesiology, and the new edition will be, and the new volume will be released this year, this weekend at the conference. Coming to today's program, this is a very important series of case discussions that we are having today. As you know, we've been holding case discussions for the postgraduate students, and this is a very important and very interesting one, child with cleft lip and cleft palate. Such an important topic. And look at this, look at the faculty who are going to moderate this. Dr. Maitree Pandey, she's the Director, Professor and HOD of the Department of Anesthesia at the Lady Hardinge Medical College, New Delhi. And along with her, Dr. Nidhi Agrawal, who's also a professor in the department in the same hospital. She's at VMMC Safdarjung Hospital, but in New Delhi. And we are so happy that you will be moderating this. And the students, of course, Maitree will be telling us, are Dr. Vasavi and Dr. Aswathi. So thanks a lot and welcome you all once again. Maitree, could you please start?
Thank you, ma'am, for encouraging words. As ma'am has already introduced, I just want to say to the students, very good evening. And actually, cleft lip and palate you get in the exams as a short case. But we will be discussing in 1 to 1.5 hours. You must be wondering for why we are taking so long. There are many important things you should not miss for exam, even to manage them clinically. It is why exams are being taken, because we want to see whether you can manage these cases safely and for a better outcome. And it is also important to know about the things which we will be discussing. And our PGs are going to answer whatever we are going to question. And if anyone has any doubt, you can always ask in the chat box, which we would be happy to answer in the end. Thank you. Over to Dr. Ashwati and Dr. Vasvi to present the case.
Good evening, everyone. So today I'm going to present the case of a child presented with cleft lip and palate.
Kindly do it full screen, please.
Yes, I'm doing it.
So, ma'am, a 1-year-old male child presented with chief complaints of visible defect in the roof of mouth and difficulty in feeding since birth. Now, history of present illness. Child was born with a visible defect of left side of upper lip and roof of the mouth. Defect of the left lip extended up to the floor of the nose and was repaired at the age of 3 months under general anesthesia, which was uneventful. There is history of difficulty in suckling breast since birth, and there is also history of nasal regurgitation of the milk while feeding. So the child has been fed using a spoon and katori in slight head-up position. There is also history of recurrent cough with fever, runny nose, and ear infections. There is no history of any pneumonia, no history of any bluish discoloration of face on crying or failure to thrive. There is no history of snoring or breath holding during sleep, noisy breathing or breath holding during feeding, or choking during feeding. There is no history of respiratory difficulty in supine position, and there is no preferred sleeping posture for the child. Now about the antenatal and family history. Antenatal history, the child is first and only child of the family, and it was non-consanguineous marriage. Mother did not take iron folic acid in the second trimester. There is no history of any antenatal infections like rubella or any other disease like diabetes and hypertension in mother. There is no history of intake of medications like anticonvulsants, retinoids, or systemic steroids. No history of radiation exposure, smoking, or alcohol intake. About the family history, there is no similar defect in either parent or the sibling. Now about the birth and developmental history, the child was born full-term normal vaginal delivery in hospital at 37 weeks of gestation and cried immediately after birth and achieved milestones as per age and immunized till date. Past history, last episode of cough and fever occurred 4 weeks back. There is no history of hospital admission for any such episodes.
So why this child is having problem in suckling and feeding?
Ma'am, suckling requires the creation of a negative pressure inside the oral cavity. In our child, there is cleft palate, and because of this inability to generate a negative pressure inside the oral cavity, because of this oronasal communication. And also there is nasal regurgitation of the feed from the oral cavity to nasal cavity, leading to hampering of the feed. And it may lead to, ma'am, in cleft lip, it may be, it is due to the inability to form the seal with the breast, especially in a complete cleft lip. And this may lead to malnourishment and anemia in these children.
Okay. So what is the cause of recurrent cough and fever with rhinorrhea and ear infection in these children?
Ma'am, as we've already learned, there is a oronasal passage which will cause recurrent nasal regurgitations during feeding. So this nasal regurgitation can cause edema and inflammation around the eustachian tube, ma'am, and can also cause obstruction of the eustachian tube. Due to the cleft palate, there may be dysfunction of the tensor palatini muscle, because of which dysfunction of the eustachian tube can occur, because of which there is no equilibrization of the pressure between the middle ear cavity and the atmosphere, ma'am, because of which there is fluid accumulation in the middle ear cavity, which can lead to hearing loss. As an anesthesiologist, it is important for us, because if we have a child with hearing loss, there can be difficulty in communication and the child may be anxious and uncooperative.
Okay, so why have you taken the history of recurrent upper respiratory tract infection, failure to thrive, and turning blue on crying?
Ma'am, cleft lip and palate may be associated with congenital heart disease, and cyanotic heart disease like tetralogy of palate may be presented with bluish discoloration of the child while crying. The most common congenital heart disease associated are AST and VST.
Yes. So you've also taken the history of snoring or breath holding during sleep, noisy breathing or breath holding during feeding. What does this suggest?
All the above mentioned clinical symptoms can be a presentation of chronic airway obstruction or obstructive sleep apnea. We have taken the negative history regarding the chronic airway obstruction because patients with cleft palate can also be a part of many congenital syndrome or sequences where retrognathia or micrognathia can be a presenting feature. This can cause chronic airway obstruction to the patients, ma'am. As we can see in Pierre-Robin sequence, there is micrognathia or retrognathia leading to abnormal posterior and downward displacement of the tongue, also known as glossoptosis, which then opposes the posterior pharyngeal wall, which will cause difficulty in, which will cause airway obstruction, ma'am. Because of this, there can be noisy breathing and breath holding. Because of the posteriorly displaced tongue, ma'am, there is incoordination between suckling, swallowing, and breathing at the time of airway obstruction, and this can also lead to aspiration and lower respiratory tract infections, ma'am. And
These children are also prone to airway obstruction during sleeping, especially in the supine position.
Supine position. So the child, if the child has the airway obstruction in supine position, they may have a preferred position of lying in lateral or prone, ma'am. Again, as an anesthesiologist, it is important for us because there may be airway obstruction when we are trying to when we are trying to induce the anesthesia to the patient during bag and mask ventilation or during during the extubation as well. If the child is facing any chronic airway obstruction in the
During
supine position.
after extubation.
Yes, ma'am.
After extubation, the child
Post-operative period. Yes, ma'am.
What about difficulty in laryngoscopy?
Yes, ma'am. In the patients that have micrognathia or retrognathia, there is difficulty in laryngoscopy and intubation. So we have, because of the less space available for tongue displacement. So we have to adopt for different techniques, ma'am, like right paraglossal technique can be adopted, or if the institution, if we have a facility of video laryngoscope in the institution, we can go with video laryngoscope, ma'am, for the better glottic visualization. And the another implication.
In these patients, if the laryngoscope can get stuck in the palate.
Yes, ma'am.
It may cause problems. So you have to take this precaution before induction.
Yes, ma'am. Gentle laryngoscopy and also packing the palate with the gauze piece. Roll gauze will help, ma'am.
And they are also sensitive to the sedative effects of opioids.
Yes, ma'am.
So these children of Pierre-Robin sequence,
yes,
is the intubation, does the intubation difficulty increases with age or decreases with age?
Ma'am, Pierre-Robin sequence, if it is isolated, the intubation difficulty tends to decrease with the age, ma'am, because there is catch-up growth of the mandible along with the age.
So what is the difference between a sequence or a syndrome?
Ma'am, in Pierre-Robin syndrome, all the components of the PRS are presented together, whereas in the sequence, one insult, that is micrognathia or retrognathia, will subsequently lead to glossoptosis and then a chronic airway obstruction and also cleft palate, ma'am.
Yes, so there is one event and followed by a sequential events.
Because of the mechanical obstruction. Yes.
But in a syndrome, probably say one congenital chromosomal anomaly will lead to cluster of symptoms and signs together.
Yes.
So syndromic PRS children, there the intubation difficulty may not decrease with age.
With the age, ma'am.
Yeah. Hypoplastic mandibles are there, which will not give a catch-up. So can you name a few congenital syndromes which are associated with cleft palate?
Yes, ma'am. As we have already discussed Pierre-Robin syndrome and sequence, there is also Stickler syndrome, Treacher-Collins syndrome, ma'am, Down syndrome, Golden Heart syndrome.
Tell me what is Treacher-Collins syndrome? What are the features in that which cause difficulty in intubation?
Yes, ma'am.
Difficult airway.
Yes, ma'am. Treacher-Collins syndrome presents with bilateral hypoplastic zygoma, mandible, and maxilla, ma'am. They also have microtia with hearing deficiency. Ma'am, micrognathia or retrognathia can be there, ma'am, which can cause difficulty in intubation. And the patient can also present with coloboma of eyelids, ma'am.
Okay, but coloboma of eyelid will not cause
difficulty. Yes, ma'am.
Coronal atresia is present, which may cause. Yes. And here also, since it's a syndrome and it's a mandible is hypoplastic,
intubation difficulty increases with the age because there is no catch-up.
Another syndrome where you know that the intubation difficulty will increase with the age?
Yes, ma'am. Golden Heart syndrome, ma'am. It is a hemifacial microsomia, ma'am, which can also present vertebral anomalies and renal anomalies.
Okay. So you said that the lip was repaired prior to the patient presenting with the palate for surgery.
Yes.
So the correct age to repair the cleft lip in these children?
Ma'am, the correct age to repair cleft lip is 6 weeks to 6 months. And some surgeons prefer to do it in the neonatal period itself. And in Millard's rule of 10 for, yes. In Millard's rule of 10 for lip closure, it says that 10 weeks of age and 10 pounds of weight, a hemoglobin of 10 gram percentage and TLC less than 10,000 can be preferred for the repair of cleft lip.
Okay. What about what is the age for the cleft palate? Preferable age for cleft
Cleft
palate?
palate can be repaired from the 6 months to 12 months of age.
Okay. So here also there is a rule of 10.
Yes,
Okay.
ma'am. For the age of 10 months, weight of 10 kg or more, hemoglobin 10 gram percentage of
rest
more.
are the same.
Yes, yes.
Why this age group? What will happen if you repair the clip? What are the disadvantages of repairing the lip earlier than 6 weeks or later than 6 months?
Ma'am, if we are doing it earlier than the 6 weeks or 6 months, the complications of the general anesthesia will increase because the child will be in a neonatal period. And if we are doing it very fast, we won't get enough time to investigate if there is any other congenital anomalies. And also at that time, the tissue will be immature. So the surgeon will face difficulty in handling the immature tissues.
So what are the advantages of repairing this during this specified period?
It helps in the suckling of the milk, and the aesthetic cosmetic repair helps in the parent-child bonding. And it will also arrest the development of alveolar arch deformity and the nasal deformity, particularly in patients with complete cleft lip.
Okay. So about palate, if the paper it is operated before 6 months, then is it preferable or not?
Ma'am, it's not preferred because it may lead to the arrest of growth of the palate and the facial-maxillary structures.
And what will happen if we repair after 12 months?
There will be impairment of the speech, ma'am. It will lead to the nasal twang of the voice due to the escape of the air from the nose.
Impairment of speech.
Yeah, impairment of the speech.
Why it is so?
Because the oropharynx is not separated from the nasopharynx. So the air will escape from the nose, which will lead to the nasal twang. So it will be difficult for speaking the plosives like PKDT and sibilants like sh and s.
So there may be velopharyngeal incompetence.
Pharyngeal incompetence. Yes.
Because of that, the nasal twang and speech disorders and difficulty in swallowing will be there.
Yes, ma'am.
Continuing with the, yes, ma'am. Continuing with the general physical examination.
Dr. Vasvi, please be brief.
Yes, ma'am. On examining the child was alert, playful, sitting in mother's lap comfortably. Pulse rate was 96 per minute, regular and of adequate volume. Blood pressure was 90 upon 54 millimeter of mercury. Respiratory rate was 18 per minute, which was regular. And all anthropometric findings were appropriate for age and weight. All the fontanelles were closed except anterior fontanelle. No signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy. Child was afebrile to touch. An incision mark of the repaired cleft lip on the left side of the lip was present. No other gross deformities of the face and neck were noted. Milestones were adequate according to the age. On airway examination, there is whitish crust and watery discharge noted from the nose. On the side profile, while examining from the side profile of the face, chin was noted to be normal. There is no retrognathia or micrognathia. Mouth opening was adequate. Bifid tip of uvula was seen. Cleft in the hard palate, posterior to the incisor foramen, extending into the soft palate, and uvula was noted. Normal dentation for age, no missing or bucktooth were noted. Neck range of movements were normal. Kopur score was 5.
So what is?
Is there any systemic in the systemic examination? Did you find any abnormality?
No, ma'am. Systemic examination was within normal limits. No event.
What would have been present in serious examination if there were some abnormality?
Ma'am, murmurs could have been noted, ma'am, and cyanosis murmur could have been noted.
So you've said that in your airway examination, you've said that Kopur score is 5.
Yes, ma'am.
So can you explain what do you mean by Kopur score?
Ma'am, there is a systemic assessment. Colorado Pediatric Airway Score is present, ma'am, to assess the difficulty of intubation in pediatric age group. As the name, as the abbreviation itself stands, C stands for chin, O for mouth opening, P for previous history of intubation or obstructive sleep apnea, U for uvula, and R for range of neck movements. Each assessment is given with score of 1 to 4, ma'am. Total of 20. Total score of 20 is being given, where 5 to 7 is considered to be normal and easy intubation.
Just tell us what score predicts difficult airway.
Ma'am, more than 10 is considered a difficult airway.
Okay, and there are certain modifier points
Yes, ma'am.
also.
Certain modifier points are there, which will add up to this score.
Yeah. Now, can you just give a small summary of the diagnosis of your case?
Yes, ma'am. A 1-year-old child with cleft in hard palate posterior to the incisive foramen extending into the soft palate and uvula with repaired left complete lip with no other congenital anomaly presented for cleft palate repair.
So, hard palate posterior to incisive foramen along with soft palate and uvula, what is it called?
Secondary palate. And
the palate, small triangular palate in front of the
primary palate.
Along with the
alveolar ridges
and the lip.
Yes,
constitute palate.
Primary palate, yes, ma'am.
So, on the basis of the embryology, can you tell me how cleft lip occurs and how cleft palate occurs?
Yes, ma'am. Ma'am, for the formation of lip, we need 2 medial nasal processes. They fuse in the midline, ma'am. This happens around 4th to 5th week of gestation. 2 medial nasal processes fuse in the midline to form central upper lip and the tip of the nose and the intermaxilla. That intermaxilla will further develop into the primary palate, ma'am. And the medial nasal process, they fuse with the maxillary process on the lateral side to form the lateral part of the lip and the upper jaw, ma'am. So any deformity in such formation or any defect here, ma'am, will cause cleft lip, ma'am.
How? So medial nasal process not fusing with the maxillary.
Yes, ma'am. Medial nasal process not fusing with the maxillary can cause the unilateral or bilateral cleft lip, ma'am, depending on the side.
Bilateral cleft
yes,
lip.
And if the medial nasal processes are not fusing in the midline, it can cause a central cleft lip, ma'am. Median or central cleft.
What about secondary palate?
Ma'am, for the palate development, there are palatine shelves, ma'am. 2 lateral palatine shelves are present at the maxilla level, ma'am. That at the age of 6 week of gestation, they grow vertically downwards towards the stomatodium. And then the palatine shelves from the vertical, when they were proceeding vertically, they will become horizontal at around the age of 7 weeks of gestation. And now the tongue that is present between the 2 palatine shelves is being withdrawn, and the 2 palatine shells will fuse in the midline to form secondary palate, ma'am. Any deformity or any difficulty in the movement of tongue outside the 2 palatine shells can cause a cleft palate, ma'am, in the secondary palate.
The failure of fusion of these 2
yes,
horizontal lateral palatine shells will lead to formation of secondary
cleft palate.
Then secondary palate also fuses
with the primary palate at the age of around 10 weeks and also with the nasal septum.
And the nasal septum. Very good.
Thank you.
So based on this, you just saw the embryogenesis of the cleft lip and palate. What are the types of cleft lip?
Cleft lip can be divided into unilateral, bilateral, or median. It depends upon where it is occurring. And it can also divided into complete, incomplete, and microform, depending upon the structures involved. Complete involves the entire width of the lip along with alveolus, and it will extend up to the floor of the nose. In case of incomplete, the cleft involves the part of a lip and it won't extend into the floor of the nose. In case of microform, it is a type of incomplete cleft which will form a notch over the vermilion border of the lip.
What is the anesthetic implication of knowing the classification of this lip? Is there any importance to you as anesthetist?
Yes, ma'am.
Whether it is unilateral or bilateral?
Yes, ma'am. If it is a bilateral, it will be difficult for the mask ventilation, and also it will be difficult for the laryngoscopy. So it is important.
Very good. And the laryngoscope blade may get stuck in the cleft. So you may have to prepare for it with a gauge or any dental plate which can be used for the proper laryngoscopy.
Yes.
And what about cleft palate? What are the types of cleft palate?
Cleft palate, if it is the primary palate, it can be unilateral and bilateral. If it is secondary palate, it is median cleft lip. And it can also be divided into complete, incomplete, and submucous type of palate, depending upon the involvement. Complete involves the whole primary and the secondary palate. In incomplete, cleft involves just a part of the palate. In case of submucous palate, the cleft will be present in the palate, but it will be covered by a mucosa. So it won't visible to the outside.
So in this too, what is your importance of knowing whether it is bilateral or complete full palate? What does, how does it, how can you relate it to an aesthetic management?
Ma'am, it is mainly important while we are doing the laryngoscopy. If there is a complete
Apart from that, in these, you will know the procedure, how long the procedure will take,
yes,
whether it will require blood or not, or and the quantum of pain will increase with the more tissue handling, and the edema and all after the operation. All these things will depend how much correction has to be done. Okay.
Yes.
So are there any classification for this, for grading these palate, and any Indian classification is there or not? We can run through these slides because due to in interest of time, we are not discussing this. So you can name these classifications.
Ma'am, there are several classification like views classification, which is the most common one. There is also Nagpur classification, which is introduced by Dr. C.K. Balakrishnan, an Indian doctor. And there is also LHMC classification, which tells about the involvement of the which all structures.
That's okay. That's okay. So now you have to take up this case, 1-year-old child, for cleft palate surgery.
Yes,
So what investigations would you like to do?
Ma'am, for my particular case, I will get routine investigations, like I'll get a hemogram done to understand the anemia status or the malnourishment. I'll get a urine routine microscopy done, ma'am. In our institute, we'll get BTCT done if it is a first surgery. Ma'am, our child has presented for a revision surgery, ma'am.
Second time, so you may not get a BTCT done.
Yes, ma'am.
Any specific investigations would you like to do if there were some congenital anomalies or something?
Yes, ma'am. If in the history and examination part, if I could assess and if any positive symptoms were there for any congenital anomalies, I would like to go for 2D echocardiography and chest X-ray, ma'am, to rule out congenital heart diseases. And I would like to go for an X-ray spine to rule out any spine anomalies. And I'd like to go for a chest X-ray, ma'am, to rule out lower respiratory tract infections.
What conditions, what kind of spine anomalies can be present?
Ma'am, golden hair syndrome can be present. It presents with scoliosis, ma'am. And if the child has a association of Down syndrome, there can be atlantoaxial subluxation, which will implicate as a difficult laryngoscopy, ma'am. And if the child also has Klippel-Turner syndrome, there can be C-spine fusion, which also is a difficult laryngoscopy, ma'am. So I'd like to rule out.
Okay, that's very good. So you mentioned in your examination that child has some whitish discharge present and whitish crusting is present. So would you postpone this case for the surgery, or would you take up this case?
Ma'am, I'll take up the case because the running nose and mucoid discharge is almost always present in this type of children due to the nasal regurgitation of feed. So
Okay.
I'll ask the mother if there is, it is always present or a child sicker than usual now. I'll ask about condition.
When will you postpone this case?
Ma'am, I'll postpone if the child is having fever, malaise, purulent discharge, or any bad chest condition like cramps in the chest. And
Suppose child had come with URTI.
Okay.
He had purulent discharge of fever and malaise. How long would you postpone this case, and why would you postpone this case?
Usually for URTI, we'll prefer to take case after 4 to 6 weeks. But in this case, there is only a narrow window during which the child will be free of URTI. So I'll
Why
take
do you
the case.
postpone? Okay.
I'll
Okay,
take
go
the
ahead.
case after 2 weeks and not like usual 4 to 6 weeks.
You did not say why you want to postpone the case for 4 to 6 weeks.
Ma'am, the child will have a hyperreactive airway during this period.
What kind of complications can occur because of that?
Ma'am, this can lead to bronchospasm, laryngospasm.
Very.
So this child has come for repair of the cleft palate.
Yes, ma'am.
So you have taken history, you have examined. So what pre-operative orders would you write in this patient?
Ma'am, I'd order for a nil per oral as per ASA, standard ASA guidelines, ma'am. I'd also arrange for blood and hold it in the blood bank for if it is a
What
cleft.
are the ASA guidelines for nil per oral?
Yes, ma'am. 8 hours for solid fatty meals, ma'am. 6 hours for light
But
meal.
this is a small child, so
Yes, ma'am. 1 year, ma'am. 6 hours for
1 year.
light meal and formula or non-human milk, ma'am. 4 hours for human breast milk, ma'am. And 2 hours for clear fluids, ma'am.
Okay. What are the other
Yes,
orders?
I'll
Like,
arrange for blood and hold it in the blood bank, ma'am. And I'll also get written and informed consent from the parents in my
so
child.
when would you like to take a high risk consent? Would you like to take high risk consent in this patient?
In this patient, no, I'd not like to get any high risk consent, ma'am. But if the child presents with any anticipated difficult airway or any congenital anomalies are present, congenital heart diseases are present, I would like to get a high risk informed and written consent, ma'am.
Okay. Would you like to write anything about pre-medication
Yes,
in the
ma'am.
pre-op orders?
Ma'am, pre-medication I will only give, ma'am, in like half an hour before the induction of anesthesia under adequate monitoring, ma'am. I would like to go with the oral midazolam, ma'am, 0.5 mg per kg body weight, ma'am.
So how much for this child? Child is 10 kg.
It is a 10 kg child, ma'am. I'd like to go with 5 mg.
Okay. What if midazolam is not there, oral midazolam? Would you like to use any other drug?
Yes, ma'am. I can also go with oral ketamine, ma'am, 5 mg per kilogram body weight, ma'am.
And what is nowadays we are using very short acting drugs.
Yes, ma'am. Intranasal dexmedetomidine can also be given at the dosage of 1 to 2 microgram per kg.
Though it is an off-label use.
Yes, ma'am.
Still
And
it is
I like to avoid any sedative premedication if I am anticipating any difficult airway.
okay. So can you tell me if the child would have been around 5 months, would you still have given pre-medication?
No,
ma'am.
ma'am. Because I'd not be anticipating any separation anxiety in a child less than 6 to 9 months. So I would not like to go about with the premedication.
They have a separation anxiety usually after 8 months, 8 to 9 months.
Yes,
Okay.
ma'am. Yes, ma'am.
So then you need these sedative drugs.
Okay. So, what is your plan of anesthesia for this 1-year-old child who has to undergo cleft palate surgery?
Ma'am, my plan is general anesthesia with controlled ventilation with a RIE South Pole tube. And yes, ma'am.
And how will you prepare before shifting the child? How will you prepare the operation theatre?
Ma'am, I'll pre-warm the OT. I'll keep forced air warming system. I'll keep warming mattresses. And I'll keep warm fluids and cotton for wrapping. I'll check anesthesia workstation, monitor, cylinders, suction apparatus, and defibrillator if at all are working or not. And I'll prepare a difficult airway cart with all age-appropriate airway equipments. And I'll prepare bolsters for positioning of the patient. And I'll also prepare pediatric fluid sets. And drugs will be loaded and dose will be calculated and will be displayed for ready reference beforehand.
So once you have shifted the child to the operation theater, how will you proceed with to anesthetize this child?
Ma'am, I'll first attach monitors after taking the patient into the operating room. I'll attach ECG and saturation probe, ma'am, and I'll start inhalational induction with sevoflurane in 6 to 8% in 100% oxygen, and then establish an IV access, ma'am. After establishing the IV access, I would like to give injection fentanyl 2 micrograms per kg, that is 20 micrograms for this child, and after check ventilation, if I can ventilate, if I'm able to ventilate the patient, I'd like to go about giving injection neuromuscular blocker, namely injection vecuronium 0.1 mg per kg, that is 1 mg for this child, ma'am. And I will perform intermittent positive pressure ventilation for around 3 minutes, ma'am. Then I will proceed with the intubating the child.
So can we do IV intravenous induction in this particular child also? Is there any problem with going
No,
ahead?
ma'am. If the IV access is already secured, I would like to go with IV induction, ma'am.
With which
There is no
drug?
contraindication.
What will you use?
I would use injection propofol, ma'am, 2.5 mg per kg.
If you are given a choice between halothane and sevoflurane, which
Yes,
one
ma'am.
would you prefer and why for induction?
Sevoflurane, ma'am.
Right?
Because, ma'am, during this surgery, the surgeon may be using adrenaline. So,
No, not that.
okay.
I am only talking about induction.
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 Ma'am,
Early-
both can be used, but sevoflurane I'd like to use, ma'am.
Rapid induction and rapid
Halothane.
Yes, both are sweet smelling,
Sweet
both
smelling.
are pleasant.
Yes, ma'am.
Sevoflurane has a low blood gas
rapid induction.
so it has a rapid induction.
Yes.
Okay. Suppose you take up the child after you ventilating the child, you've given a muscle relaxant, and you find that you're not able to mask ventilate the child. What could have happened? How will you manage?
In my particular case of cleft palate, difficulty in mask ventilation could be due to the tongue getting lodged into the cleft palate, ma'am. So firstly, I will discharge the tongue that is there in the cleft palate, and then I will optimize my head and neck position again. And I will also give, if the bag and mask ventilation is not getting improved, I'll further go with giving jaw thrust and also introducing a oropharyngeal airway, ma'am. If further it doesn't get improved, I will go with gastric distension, deflation of the stomach in view of gastric distension that might have happened.
The
Yes.
stomach is inflated. If you
Inflated.
find that stomach is
inflated,
then you will go
excessively,
for
then I'll
deflation.
go for deflation of the stomach.
What is the position for intubation in this child? What position of head and neck would you like to keep for intubation?
I'll position the child in a way that the external auditory meatus is in line with the sternal notch. For this age group, there will be large occiput, so which will make the head flex. So I'll keep a shoulder roll to extend the head, and a pillow will be kept to stabilize the head.
What kind of laryngoscope would you like to use?
Ma'am,
Straight
I'll
or
use
curved?
a straight blade Miller laryngoscope because it is preferred in infants.
Why it is preferred?
Ma'am, because of the large epiglottis, we have to use
long choppy epiglottis. It is easy to lift it.
Yes.
Directly lift the epiglottis away with a straight blade. Okay. But some people are comfortable with the curved blade also. So there's no contraindication using that also. It depends on your experience with the device.
Yes.
So we've already talked about difficulty of laryngoscopy. So, as the blade can get stuck in the large palatal cleft, or in cases of large cleft lip, if the alveolar cleft is large, so you can pack it with a rolled gorge. And what is premaxilla? What is protruding? You can see in this picture.
Yes.
When this condition occurs of premaxilla, when there is a bilateral complete cleft lip, then this premaxilla, there will be difficulty in introducing your laryngoscope. So in these cases, use right paraglossus because introduction of the laryngoscope will not be very difficult. Now you talked about that your plan is to use RAE tubes. So you said South Pole tubes. You can see in the picture here, this one is the South Pole and this one is the North Pole.
Yes.
So what size of RAE tube would you use for this child of 10 kg?
Ma'am, I'll be using the formula H/3 plus 3.5. I'll be using means for the uncuffed tube, I'll be using a cuffed tube of 3.5 size, or an uncuffed tube of 4 size can be used.
Sometimes RAE tube 3.5 cuffed tubes may not be available.
Yes.
So millimeter uncuffed tubes are quite freely available, RAE tubes.
Okay.
Those can be used.
Yes.
Okay.
Even if you know the size, what other things will you see while you are intubating this child? Maybe you have calculated.
Yes. Ma'am, I can see the little finger of the child and the.
Yes.
I can see the.
Or while intubating, whether it is too tight or too loose, you can correct it then and there.
Yes, ma'am.
Okay. So,
what is the advantage of cuffed tube or uncuffed tube? You can be asked these questions. We are not going ahead with this, but you can be asked. Okay. Yes. And about the cuffed tubes also in exam. So now you want to use an RAE South Pole tube.
Yes,
why are you preferring it?
Ma'am,
in the case of cleft palate or cleft lip.
Ma'am, for the RAE cuff tube, there will be a proximal bend in the tube. So it helps to take the tube away from the surgical site along the chin. And thus it will prevent the kinking of the ETT while the surgeon places the mouth gag. Any other reason why this tube is fixed in the midline? This tube is fixed in the midline, as you know. Yes, so why this tube is fixed in the midline? Ma'am, for the cleft palate repair, we are using Dingman's dot mouth retractor, and there is a slot in this retractor which is over the midline area. So this avoids the compression of the ETT. So it comes in the midline.
Right. So this slot of the Tingman gap, this is a tongue plate. This is used to retract the tongue away and open up the cavity, oral cavity, so that the site can be accessed well. So you can see here that there is a slot which can accommodate a tube here. Here you can see that the tube and the tongue have both been retracted away. And because of this slot, it is in the midline, the tube is fixed in the midline, and the kinking of the RA tube can be prevented. And there's this horizontal part of the mouth retractor which is going above the tube, and the tube is below that. It has curved very nicely along the chin so that it is not kinked or compressed by the horizontal part of the gag. So, and what is the reason of fixing the tube in midline and cleft lip?
Ma'am, to maintain the symmetry
In
of
cases of
the
there is no
cosmetic, yeah.
Yeah.
Maintain the symmetry of the lip.
We want to keep
Yes,
the lip
the-
symmetrical so that cosmetic repair can be
Yes,
done.
by this we can avoid any
Because it's a cosmetic
infections.
repair.
And
And
fixing is
while
very
taping the
important.
endotracheal tube to the cheek, avoid any facial distortion.
Yes,
Okay.
yes.
Now, talked about the advantages of RA tube. What are the disadvantages of RA tube?
Ma'am, first of all, there is a bend, so it will be difficult to suction this tube. And second thing is that the length of the preformed bend is fixed, and therefore it varies with the tube size and may not fit the all patients. So in case of a small infant, the preformed curve of the RA, which is of appropriate size for the child's tracheal diameter, may protrude out too much above the chin. So in this type of cases, we'll have to use a smaller size of RA tube, or we can also use a flexometallic tube. And in case of big infants,
Smaller size RA tube has to be cuffed so that there is no air leak, because this has a fixed length. And this fixed length increases with the size of the tube. So to decrease this bend size, you have to take a smaller tube which would be cuffed. Again, it would be better if we can use a flexometallic tube of appropriate size.
Yes.
Okay. And if it is, if it's a larger baby, and
the proximal
bend would be inside the
RA tube, inside the oral cavity. So it will get kinked during the insertion of the gag. So we can use a flexometallic ETT in this cases.
Very good. We can use a flexo, because flexometallic tube will not get kinked even if we fit it. Yeah. And another alternative is Oxford tube, which generally we don't find very frequently now. It is almost obsolete.
Yes.
One problem with Oxford tube was that the cuff was high pressure and low volume.
High pressure.
So which is not recommended for children. That is why it is out of use.
Yes.
Yes.
So when you have intubated the patient and you will hand over to the surgeon, so what is the position of the child you would like to make before giving to the surgeon for surgery?
Ma'am, for easy access of the surgery, for the cleft palate repair, I'd like to hyperextend the head and neck position, ma'am. This is called rose position. To make it possible, I will lift the whole body of the child by raising it on a pillow, and then the head and neck will be protruded or brought out of the pillow, ma'am, and then hyperextended, ma'am. But to stabilize the head, I'll put a head ring or a towel, ma'am. And during position,
what problem can occur while positioning?
Yes, ma'am. While doing hyperextension, there can be accidental extubation of the ET tube, ma'am. So I have to be very careful while doing this, ma'am. In case of cleft lip, ma'am, shoulder roll is placed and head and neck is just extended for easy visualization of the.
What other advantage this position has when you are putting on hyperextension and
Ma'am, the debris will not trickle down into the trachea, ma'am. So my airway is also protected from spasm.
So it will be
collected in the cavity where suction can be done adequately.
And it will be away from the larynx, opening of the larynx. So aspiration, microaspiration, even though you pack these patients, pack the throat, microaspiration can occur.
Yes.
So it will prevent it. This position. And what other things will you do? What other...
Yes, ma'am. After positioning the patient, I'd like to fix my breathing circuit and step to a straight connector, and I'll fix it on stabilize it on the chest of the child, ma'am. And I'll have to be very careful all throughout the surgery because it is a shared airway surgery, and accidental dislodgement of the tube, accidental extubation, and accidental endobronchial intubation can also happen, ma'am. So for that, I'll have to have a good communication with my surgeon, and most importantly, I'll prevent any eye injury, ma'am, by taping the eyes closed.
Okay, very good.
So, you have to apply
Why did you
Dingman
pack
and
this
Dot
pharyngeal
prep.
packing?
Okay.
You already told, no? Pharyngeal packing will be done in the cleft palate after application of the Dingman dot retractor.
Yes,
Why?
ma'am, for cleft palate, surgeon applies the retractor and then under vision they will pack, ma'am.
Because if we pack it beforehand, the area may be covered with the pack.
Yes,
So
ma'am.
the surgeon likes to pack the throat
After placement of the
after the Dingman dot.
And placement of the pharyngeal pack is extremely important, ma'am, because it will collect all the debris, it will collect all the blood and secretions that are getting pulled up in the area. It will help the surgeon to maintain a clear area, and it will also help the patient without to prevent any microaspirations.
So what will you look for the during placement of Dingman dot retractor? When you are applying it, the surgeon is applying it, what will you look for?
Ma'am, during retractor application, we
Application of
should
it.
see whether it is compressing the ATT. So if the child is in a volume control mode, we can see whether there is an increase in the peak airway pressure. And if the child is in a pressure control mode, we can see that the tidal volume will be decreasing. And if the child is in a manual ventilation, there will be decrease in the compliance of the bag. And after all this, we have to ask the surgeon to adjust the retractor again if the compression of the tube is detected.
Okay. And you will also auscultate, do bilateral auscultation of the chest.
Endobronchial pushing can happen during the application of the retractor. So bilateral air entry should be confirmed.
So whenever you are doing a case with shared airway, it is always advisable to put a precordial stethoscope. You usually fix the precordial stethoscope so that whenever required, you can check it because you are away from the site.
Yes,
At the
sure,
last moment, you are not able to put the stethoscope.
Yes.
So it is better if you
Okay.
put it before.
Yes. So we all know that the surgeon infiltrates the surgical site, the palate, with adrenaline. So
Yes, ma'am.
why do they infiltrate the adrenaline and what is our concern? First, tell me why do they infiltrate the
Ma'am,
site with
adrenaline
adrenaline?
causes vasoconstriction, ma'am, which will help with the decreasing the bleeding, ma'am, and it will provide a clear field for surgeons, ma'am, and for the dissection of the tissue. That is why they infiltrate with adrenaline.
What is the dilution of the adrenaline that they are using?
Ma'am, 1 in 20, 2 lakhs, ma'am, that is 5 micrograms per ml.
Very good. So why are we concerned with the use of adrenaline?
Ma'am, because inhalational anesthetic agents, they sensitize the myocardium to the exogenous catecholamines, ma'am. So as we are using inhalational anesthesia, along yes, ma'am, arrhythmias intraoperatively.
So what will you tell the surgeon? How much dose should be used?
Ma'am, it depends on the inhalational agent that I'm using. Most commonly used inhalational agent in pediatric age group is sevoflurane, and for sevoflurane and isoflurane, it is up to 10 micrograms per kilogram body weight, ma'am. And if I'm using halothane, I'll ask only for I will allow only for up to 5 micrograms per kilogram body weight, ma'am, as it predisposes to arrhythmias more.
Yeah, for this 10 kg child,
yes,
how much?
Ma'am, if I'm using sevoflurane, 10 kilogram child, so 10 mics per kg, 100 micrograms are allowed, ma'am. I'm using 5 microgram per ml dilution, so I'll allow up to 20 ml, ma'am. I will make sure that the dosage is not exceeded.
Okay. So some surgeons also use lignocaine in infiltration, lignocaine with adrenaline infiltration. In our institution, they are only using 0.05% of lignocaine with 1 in 2 lakh adrenaline. And it helps, this administration also helps raise the flaps well.
Yes,
okay.
Yes,
for the mucocutaneous flaps are raised well. I don't know how much 0.05% will contribute to analgesia. Now, fluid management, blood loss management, and hypothermia are common to all pediatric cases, and they can be asked to you.
Okay.
Am I audible?
Yes, ma'am. Yes, ma'am.
Yes.
Okay. So Due to lack of time, we are not covering them here, but they can be asked to you in this case.
Yes.
Now,
So
let's
you
come to
know how to
intraoperative
assess
analgesia.
blood management.
What analgesia? Yeah, they can be asked. So what multimodal analgesia, what analgesia would you like to give?
I'll prefer a
To this child?
multimodal analgesia. So multimodal analgesia helps in the smooth emergence and less crying and less bleeding and less swelling of the surgery. So I'll use injection paracetamol 15 mg per kg IV infusion, or I can also use a suppository of PCM. And I'll be
Is suppository available in your institution?
yes,
PCM suppository?
yes,
So,
ma'am.
what is the suppository dose of PCM in suppository that is available?
Suppository dosage is 25 to 40 mg per kg.
Dose. I'm saying the suppository milligram of paracetamol available in the suppository.
Ma'am, it's available in 250 mg, 500 mg, and it's also available in 80 mg.
50 mg?
Yes, ma'am. But in our institute, it's available in 250 and
80 mg or PCM or 120 mg PCM suppositories and higher ones.
Yes.
Okay. So you've given paracetamol. What else would you like to give?
During induction, I'll be giving injection fentanyl twice per kg IV. And after induction, I'll use injection morphine 0.05 mg per kg IV. In some institute, they prefer.
Any other drug?
Yes, ma'am.
Any other drug at the time of induction which you can use, which will also lead to analgesia, decrease the airway edema, decrease PONV?
Dexamethasone.
At the time of induction?
Yes, ma'am.
Yes,
Injection
Yes,
dexamethasone.
dexamethasone.
0.1
also we give at the time of induction.
Yes.
Do you give any regional blocks for palate?
No, ma'am. In my institute, it's not giving, but there are regional blocks which can be given for cleft palate surgery.
Name them. Can you name blocks?
Ma'am, bilateral maxillary nerve blocks can be given via a suprazygomatic approach. And there is also single nerve blocks like bilateral, lesser and greater palatine nerve blocks and nasopalatine nerve blocks. There is also sphenopalatine ganglion block.
This surgery?
Yes, ma'am.
Okay. This surgery is involving only the secondary palate.
Yes,
so which two individual nerve blocks would you like to give?
Bilateral lesser and greater palatine nerves with and naso. Yes, ma'am. Bilateral lesser and greater palatine.
Lesser and greater palatine nerve blocks supplies the hard palate and soft palate and uvula.
Yes.
Nasopalatine nerve block supplies the anterior palate.
Anterior palate.
We are not doing the surgery of that, so nasopalatine nerve block is not required.
Yes.
So even if you are not using these blocks, you should know the nerve supply of the palate. Yes. Now here only I would like to cover a block that we very frequently give for cleft lip. What is that block?
Infraorbital block, ma'am. It's a branch of maxillary division of trigeminal and it exists from the infraorbital foramen. So we can give the infraorbital nerve block through the percutaneous approach, or we can also give it by an intraoral or a USG guided approach.
So we are generally giving it by percutaneous approach. Yes. So you should know the technique of this block. Yes. It will be asked in exam. And also what drug is used. Generally 0.5 to 1 ml is given for each side. Okay. Yes. And 0.125% and 0.25% of bupivacaine or 0.2% ropivacaine. Yes. And effect lasts for analgesia lasts for 4 to 6 hours to 6 to 8 hours depending on the concentration of the local anesthetic used.
It is very important to know that when you are performing this block, you should not give this block into the foramina. It should be lateral to the foramina. Otherwise, it may cause edema of the nerve and some problems with the nerve injury. It may cause nerve injury. Okay. So when you're performing, you should take care of these things.
Okay, ma'am.
And you should also keep your hand over keep your finger over the inferior orbital margin.
So you do not
enter the eyeball with your knee.
So now the surgery is completed and you hand over he hands over the child to you. How will you proceed?
Ma'am, after the surgery is completed, I will do a gentle check laryngoscopy done, ma'am, and I will suction out all the debris, blood clots that are collected in the oral cavity.
What else can be done? What else can you ask the surgeon to check the field?
Yes, ma'am.
What else can be done? You can ask them not to remove the retractor.
Yes, ma'am.
Put the retractor in, they're the best possible
Is the
view
best
you
for
get.
us to visualize. Yes, ma'am.
Yeah.
Yes, ma'am. Either with the retractor or by doing a gentle check laryngoscopy, I will make sure that there is no clots, debris, and blood that is being
Why do you
collected in
want
the oral
to
cavity.
do it under vision? Normally you do suction after the operation is over. Why
Yes,
do you want to do with the help of a laryngoscope?
Ma'am, to prevent any disruption of the palatal sutures, ma'am, as the operative field also is where my suctioning, I'm suctioning, so I don't want to disrupt any palatal sutures, ma'am. And I will make sure that the throat pack is removed under vision, and oral cavities will be examined after that also for any to ensure that the hemostasis is achieved and no more blood clots are being left in the oral cavity. And ma'am, by doing this simultaneously, I will also check for swelling of any structures, ma'am, like tongue, pharynx, and the uvula. I will check for the swelling of the structures. Because, ma'am, if the swelling of the structures is present, I will try to postpone the extubation, ma'am. I will defer extubation and I will electively intubate the child and mechanically ventilate.
Intubate, the child is already
As in
intubated.
intubated, ma'am, I will mechanically ventilate.
Continue
I
with
would
the
just like to make one small point.
Yes,
Can I make one small point here? Normally, because there is risk of bleeding in the post-operative period,
yes,
our surgeons, plastic surgeons, do not, remove their gloves or do not wash off. They stay there till we tell them that okay, hemostasis has been achieved.
Okay.
So they stay, keep washed up, washed up till we tell them that hemostasis has been achieved. So this is a rule, because sometimes even when they say that the hemostasis has been achieved, after few seconds, we can see blood coming, oozing from somewhere. So that is the norm.
So why it is so important
Ma'am, you can
to achieve the hemostasis? Why are we so worried about achieving the hemostasis?
Ma'am, if there is continued oozing or if we had missed out on any clot, this can be a potential risk factor, ma'am. This can be a trigger for spasm. This can be a trigger for airway obstruction post-operative.
Airway obstruction can occur in the post-op.
Yes, ma'am.
So how will you extubate this child? Suppose there is no swelling, everything is clear, no bleeding is there. How will you proceed for extubation?
I'll reverse the neuromuscular blockade using the neostigmine with a dose of 50 mics per kg and glycopyrrolate 10 mics per kg. And I'll be giving ondansetron 0.1 mg per kg IV 30 to 40 minutes prior to the giving reversal. This is for preventing the PONV. And after giving that, I'll prefer to keep the child in a lateral position so that there won't be any aspiration or airway obstruction during the extubation. So the child will be.
How will you know that the child is fit to be extubated after giving the reversal?
I'll see whether the child is fully awake, opens the eyes, the airway reflexes are intact and complete, neuromuscular recovery has occurred. I'll see whether the tidal volume is adequate, whether the respiratory rate is
and regular and anti-gravity movement of the limbs are there. So it is very important to see all these things, because if the reversal is incomplete, then problem will occur and repeated intubation may lead to disruption of the sutures.
Yes.
So you should be very careful while extubating that the fully recovery of neuromuscular blockade has occurred.
Yes.
So while extubating, what other maneuver will you do?
I'll give a forced positive pressure inflation so that the tracheal secretions of blood that is remaining inside the tube will come out during the extubation.
Okay, good. So now, in what position will you shift the patient to the recovery?
Ma'am, I'll shift the child in a lateral position with the head dependent and extended position so that if any blood or secretions, it will accumulate in the dependent cheek so that it will drain out of the mouth.
So any further airway involvement or any spasm can be prevented. Okay.
Okay, now some surgeons put traction tongue sutures. In our institution, there's a very routine thing that a tongue suture is put and it is then loosely attached to the cheek, pasted onto the cheek. Why is that so? What is the use of this?
Yes, ma'am. Long traction suture is generally attached, ma'am. to prevent the tongue that is getting to prevent the fall of tongue onto the posterior pharyngeal wall and further causing airway obstruction, ma'am. Because post operatively, because of the tissue handling, there can be a bit of edema, and sudden decrease of the sudden correction of the cleft palate can reduce the oral room in the oral cavity, ma'am. That can aggravate the airway obstruction, ma'am. So to prevent this, tongue suture can be taken, ma'am. And
Okay, very
suture will
good.
be removed after excluding airway edema and obstruction in the evening of the surgery.
Yeah, and in some institutes, they put it only for the children where there's ptosis present or macropleusia
Yes,
or other causes of ASO present. But
Yes.
in our institute, it is done for all
All.
cases.
Okay.
So you very rightly said that after the extubation and the post-operative period, there can be airway obstruction because of edema of the oropharynx or nasopharynx or
Yes.
the swelling of tongue. Can you tell me why there is swelling of the tongue or the palate in the post-operative period?
Ma'am, this is mainly due to
Why
venous
swelling of tongue?
engorgement. Ma'am, sorry, ma'am.
Venous engorgement because of,
Because of
am
the
I audible?
compression
Yes,
due to the mouth gag, ma'am. The mouth gag will compress
Yes.
the tongue, so there will be venous engorgement.
Also because
So
of
we
the
have to,
perfusion injury.
yes, ma'am. So we have
you
to
have to
ask the
release
surgeon.
that periodically. You have to ask the surgeon to
Yes.
release it after 1 hour or so. They say it, but obviously we don't do it practically. It
Yes.
is very difficult to release. But if it's a very long surgery, maybe going up to 4 hours, we can ask the surgeon to do that.
Yes.
And what other causes of airway obstruction that you know of that can occur in the post-operative period, besides the one that you have mentioned?
Yeah, if we leave behind the throat pack, if we forgot to remove it, can also lead to airway obstruction. And also any gel form pieces or blood clots, if left behind, can also lead to airway obstruction. And laryngospasm
Pieces
is
or surgical
yeah,
from pieces and surgical can sometimes
yes.
fall off from the side and block the larynx. It has happened with us once. And very commonly, laryngospasm can occur.
Yes.
Okay, and another post-operative complication is bleeding from the surgical
Yes.
site, which
Yes,
just said. So now, suppose the patient has gone into laryngospasm. So first, tell me what is the cause of the laryngospasm, and how will you manage?
Ma'am, it may be due to the blood or debris that tricked down to the trachea, that larynx, that stimulated the closure of the glottis, or it
And it
also
occurs more during live plane of
high
anesthesia.
plane of anesthesia. Yes, ma'am.
So how will you treat this laryngospasm?
Ma'am, if it's
How
a
will you know it is a laryngospasm?
ma'am, if it's a partial
How do
laryngospasm,
you-
there will be a inspiratory stride. There will be rocking board movement of the chest, and sometimes oxygen desaturation, and along with bradycardia can occur, ma'am.
Okay, so how will you manage?
Ma'am, in partial laryngospasm, first we have to give positive pressure to the airway with 100% oxygen. We have to keep the mask tight and jaw thrust to be given. And along with this, we have to give a Larsen's maneuver, that is bilateral firm digital pressure on the styloid process, that is behind the ramus of the mandible and anterior to the mastoid process. And we can also
What does this Larsen's maneuver do? What does this Larsen's
and
maneuver
it will
do?
release the muscle relaxation.
It is to prevent, it can also be to prevent the laryngospasm or to break the reflex
Break the
laryngospasm
muscle. Yes.
that occurs. So, and CPAP of 10 to 15 centimeter of water is required.
Yeah.
We never, in these cases, never give IPPV. Sometimes we try to give IPPV, it will push the air into the stomach. Okay, we
Yes.
just close the valve to 10 to 15 centimeters, APL valve, and give positive pressure. Now, what else? Go ahead with your management.
Ma'am, after that, I'll do a direct laryngoscopy gently, and a gentle suction will be done in the larynx so that I can clear all the secretions, blood, and any retained packy is there. I'll remove it also. And
If this does not,
even if it
if
is
this
not
does not
relieved,
break the
yeah, I'll deepen the plane of anesthesia by using IV propofol at a dose of 0.3 to 0.8 mg per kg. And even after that, it's not relieving, I'll administer succinyl choline. So 0.1 to 0.3 mg per kg.
And if it's a complete laryngospasm, then
I'll apply
what will you do?
positive pressure, and if it's not helpful, I'll give succinylcholine to relax the vocal cords.
So, ma'am, now we come to the final question.
So, suppose this child was a case of a peri-Robin sequence was posited for cleft lip palate. Would the management differ? Would the
Yes,
anesthetic
ma'am.
management differ? Yeah.
Yes, ma'am. Anesthetic management will differ if the child is a known case of Pierre-Robin sequence, ma'am, because it is an anticipated difficult airway. So first, as it is an anticipated difficult airway, I'd like to proceed differently, ma'am. I'd like to get a high-risk written and informed consent from the parent or the guardian in view of requirement for post-operative mechanical ventilation, and also in view of emergency tracheostomy if the airway could not be secured. And I'd like to, this is a difficult airway, ma'am, there is a multidisciplinary approach. Both the surgeon, OT team, and also the ENT specialist will be informed about the case. Case will be taken as the first case on the OT table that day in the morning, and emergency tracheostomy cart will be put ready. I will make sure that all the drugs, difficult airway cart, and other age-appropriate equipment is put ready, ma'am. I will plan for, also this can be a difficult extubation, and I will put airway exchange catheters of the requirement and adequate sizes ready, ma'am. Senior experienced anesthesiologist, and along with the first-handing anesthesiologist, skilled experienced assistant with pediatric experience will be handling the airway, ma'am, and minimum attempts will be taken.
So these two people with the other team must
Yes,
make
ma'am.
a plan A,
Yes, ma'am.
and the
And a
backup
plan
plan
B.
should be there.
Yes,
Because it is a difficult airway.
Yes,
So
ma'am.
plan A may not succeed.
Yes,
So
ma'am.
why do you want to make plan B? Is it important to make
Yes,
another
ma'am.
plan?
Yes,
Why?
ma'am.
Yes.
If I'm not able to succeed with the plan A, this is already a difficult airway, ma'am. So plan B should always be there to, and it should be communicated well to the whole team so that everybody is learned about it and ready to perform accordingly.
Because in neonates and infants, it is very important
Yes,
to
ma'am.
prevent hypoxia.
Yes, ma'am.
Because the oxygen demand is high. So the apneic period is shortened in this. So you
Yes,
cannot continue for long.
Yes,
So
ma'am.
it is important that you do oxygenate the patient. You may
Yes.
not be able to intubate the patient, but oxygenation is
Oxygenation
important.
Yes.
So at any cost, you have to oxygenate this infant.
Yes,
So that you can prevent hypoxia.
Yes, ma'am.
Okay.
So make sure that you put in IV access
Beforehand. Yes,
anesthesia in any difficult case.
Yes, ma'am.
Okay, it's a must.
Yes, ma'am.
Because if you're doing an oxygen, if you're doing a inhalational induction with sevoflurane, and before the plane is deep, the child goes into airway obstruction, then this IV access will save you. You can supplement that inhalational agent with ketamine or small doses of ketamine or very small dose of propofol, which does not cause apnea. So always have an IV access before starting any difficult airway, and preserve spontaneous ventilation.
Yes.
And we also nebulize these kits because you are putting the plane with sevoflurane, and sometimes this nebulization with lignocaine, it will help you prevent using higher doses of sevoflurane.
Sevoflurane, yes, ma'am.
Which will lead to depression of the spontaneous respiration. So you can put any airway or mass ventilation can be done in a lighter plane.
Yes,
with the use of this. And if you are having difficulty with mass ventilation, especially with micronathia or retronathia, you can put in a supraglottic
airway, ma'am. Yes, ma'am.
It is very important to use that airway through which you can intubate. Like, which are those supraglottic airways? Yes.
It can be used as a conduit, ma'am. I can use AMBU or again and Blockbuster LMA, iGel. I can use these as a conduit for fiber optic intubation, ma'am, if difficult airway occurs. So topicalization of the airway will reduce my requirement of inhalational or intravenous agent depending on the agent that I choose. And airway spontaneous respiration will be preserved, which is important in difficult airway cases. I will make sure that the oxygenation is never abrupted. I will pre-oxygenate and also para-oxygenate. Yes, ma'am.
Para-oxygenation is also important, though you are giving oxygen through the mask, but you will also do para-oxygenation. What does that mean?
Ma'am, para-oxygenation will be oxygenating the patient while attempting airway, ma'am, while attempting to intubate.
device is used like
Yes,
nasal
ma'am.
prongs.
Nasal
So
prongs,
that
ma'am.
when you are taking off the mask, the oxygen is still continuous.
Continued
To
with
oxygenate the patient.
yes,
Okay.
ma'am. Yes, ma'am.
And preferably in these patients, you should do check laryngoscope.
Yes, ma'am.
And if you have a video laryngoscope, it would be wonderful.
Yes, yes.
So you can proceed after this. If
Yes,
it is visualized, you can intubate.
Yes,
And
ma'am.
if you do not visualize, then you can put in a
Supraglottic airway and then
Supraglottic
use it as a conduit for a fiber optic intubation, ma'am.
And do a fiber optic route. And
Yes,
I would like to make a comment here that I have been using ketamine in the doses of 0.5 milligram per kg for doing sedated fiber optic intubation in these children, and it is very effective.
Okay.
So it can also be used as a sole agent,
Sole
it
agent,
not sevoflurane. And in children where there's very severe airway obstruction, where you do not even want to use inhalation agents, you can insert a blockbuster LMA or an embu again in a topicalized airway, and then you can use fiber optic intubation, guided intubation through it, or you can induce your anesthesia under spontaneous ventilation, and then do a fiber optic guided intubation if you can maintain the airway well with the SAD.
Okay.
Ma'am, anything else you would like to add?
No, with this we
I think
come
we
to the
have-
end, because I think we are nearing the time slot we were allotted, and we would love to answer any questions which are in the chat box. And we can summarize it by saying that it is very easy to discuss all these things, but you must have first-hand experience when you are managing these patients, so that it have zero tolerance. You should not make any mistake when you are managing these children. So proper planning and discussing with the team is very important prior to anesthetizing these children.
Yes.
Thank you. So any questions in the chat box?
Yes, ma'am. Yes, ma'am. I'm Shikha. So, ma'am, I have checked, ma'am, but till now we haven't received any questions, ma'am.
Yeah, there are no questions as such.
Acha.
Okay. So,
Seems that we have discussed almost everything. and
Yeah,
there are
the topic has been dealt with very
questions.
extensively, and it was a wonderful discussion, and both the PGs really answered very well. Very nicely framed questions, ma'am, and very crisp answers, very nicely done. Excellent, ma'am.
So, ma'am,
Excellent.
just now I have received a question. I'm putting it in the chat box, so you can take it, ma'am.
can you read it?
There's something she has sent. Yeah.
Deeper or awake? Awake extubation.
Awake extubation, yes.
I can't hear.
Which one is
I
better,
can't hear the
awake
question.
intubation or deep extubation? Sorry, awake extubation or deep extubation at the end of surgery?
Deep extubation is never done in cases of difficult airway. And these children should always be awakened. Their airway, it's an oral surgery. There would be secretions of blood in the oral cavity. They are sharing the airway. So we would never do a deep extubation in these kids.
Airway reflexes are very important when you are extubating this child, because everything will go inside the trachea if you are doing extubating and in the deep anesthesia. So gag reflex, airway reflex is important when you are extubating these children.
Yeah, absolutely, ma'am. Any other question?
Ma'am, this is the only doubt, ma'am. I have received. Just allow me. No, ma'am. That's all, ma'am.
Uma, should we conclude then?
Yes, ma'am. If you want to add anything about cleft lip, cleft palate, you can do that, ma'am.
The experts have done such an extensive discussion. There's nothing left except what I can say is, of course, heartiest congratulations and thank you to Maitree and Nidhi. But what I want to just tell the students was that right in the beginning, ma'am had said that these questions, this comes in your short case, and the questions that have been asked have been so well planned. The questions have been so well planned, and I advise all the students that I do hope you have these procedures done in your hospital. So do take a chance and do see them right from the beginning to the end. So then once you have seen them, then in your exam it becomes easier. Some places don't have these. Then you ask your HOD, you know which hospital might be having it, that to give you a chance to go and see those cases. So practical experience will then help you answer in your practicals, because usually this will be a practical question, this in case. And of course, sometimes it comes in theory, but usually it is there. So that will help you a lot. And Madam Maitree and Nidhi have done, of course, covered right from the beginning to the end. So Uma, there's really nothing
Yes, ma'am.
I can add.
Yes, ma'am.
And surely both Vasavi and Aswati have done so well. Heartiest congratulations.
Thank you, ma'am.
Today, Dr. Sanish is not online, so he will be sending your certificates by email, right? So I can't give them to you today. You'll receive them tomorrow.
Thank you, ma'am. Thank you so much.
I'm really thankful for my team for putting in such effort, especially Dr. Nidhi, Vasvi, and
Yes, yes,
and they have really helped making this thing a success.
very
Without
true.
their help,
Thank you,
it would
ma'am.
not have been possible.
That's so true, Maitree.
Thank
so
you, ma'am.
true.
Thank you so much thank you for giving us this opportunity. So honored.
Lovely, lovely. So thank you so much. Thanks, Uma. Thanks, Mosumi.
Thank you, ma'am. You are the driving force.
So see you all.
Ma'am.
Of course, the ones who are coming to Lucknow, see you all this weekend, and others we will see meet next Wednesday. Thank you so much, Momita. Thanks a lot,
Thank you so
dear.
much.
Thank you,
Bye,
Thank
ma'am.
you so very
Bye.
much, and for being a
Bye-bye.
part of this
Good night.
wonderful session. So we'll look forward to connecting you again soon. Thank you so much, everyone.
Bye-bye. Good night.
Good night.
Good night. Good night. Bye-bye. Bye-bye. Bye-bye.
Chalo.
Thank you so much, ma'am, for all the guidance.
You both did very well. Very nice. Thank you.
Thank you, ma'am.